Hi everybody, this is Will Hall, and I'm going to be taking you through this presentation on some of the key findings from the Maastricht World Survey on Antipsychotic Drug Withdrawal, looking at 4,406 people that we interviewed. First of all, I want to thank all the different collaborators and contributors, my study committee, people who gave feedback, people who were involved with participant recruitment, the support that I got from so many different people, the translators, and especially my co-author collaborators on some of the publication work that we're doing with the survey data. Just an overview. So the vision of interviewing people who had been on antipsychotics around their experiences with trying to come off came from discussions in patient survivor support groups, advocacy groups such as the Freedom Center in the United States that I was involved in. I myself am someone with lived experience of a psychosis diagnosis, and I've taken a number of different antipsychotics. I don't take antipsychotics now. In developing the survey design, I created a crowdsourced input survey, and there were about 100 people who responded in English and German to questions about what they wanted to see in the survey and how they wanted it developed. So that was an important part of the input. The survey itself is 167 questions, basically very simple multiple choice and Likert scale with opportunities for narrative responses. The inclusion criteria: 18 years or older, you withdrew or tried to withdraw, and you're not under any forensic or court-ordered treatment. We were collecting data from May 2018 to October 2024, and we received 6,690 respondents from 77 different countries in 12 languages. Now, that was reduced for less than 5% completion, also for people who didn't meet the inclusion criteria, which left us with about 4,400 people in the sample. The data set's available for review and collaboration, and you can also contact me through antipsychoticwithdrawalsurvey.com for reports on the study results and to get on the email list. The question areas really tried to get a comprehensive overview of people's experience with withdrawal. There were demographics as well as people's clinical background looked at. We looked also at motivations, methods, people's attitudes towards the process, their relationship with their prescribers, as well as their different supports, the strategies they used for coping with withdrawal, what the withdrawal experience was, as well as the outcome of their attempt to withdraw. Most of the respondents were from North America and Europe. We also had people from Latin America and the Caribbean, Australia, New Zealand, Asia, the Pacific, and Africa. So in terms of motivations to come off, about 83% of the respondents said that their motivation was adverse effects. And that included 52% who said that the adverse effects were not recognized by their doctors, and 31% who said that the adverse effects were recognized by their doctors. The long-term effects were also cited as a motivation for 43% of the respondents. 36% said that the medications made their condition worse. 28% said that they never helped. 28% also said that they felt better and no longer needed the medication. Only about 10% reported that it was a doctor that motivated them to come off. So one of the questions that gets raised about a survey like this is, are we skewing on the side of people who have less severe clinical conditions? And so we looked at that. About 48% of the respondents reported being diagnosed with psychosis. 78% had been in psychiatric inpatient care. 20% had been homeless. More than half, 53%, had attempted suicide. And about half were receiving some kind of public benefit payments, primarily psychiatric disability. And we also looked at, of the people who reported successfully coming off antipsychotics, how long had they been off? And more than 50% had been off for more than a year, with about 47% being off for 2 years or more. The most recent diagnosis was predominantly schizophrenia with schizoaffective disorder, bipolar with psychosis after that. Overall, about 80% of the sample had been on antipsychotics more than a year, and 70% had been on 2 years or longer. So we decided to break the respondents down into 4 different outcome cohorts: people who were off all medications, people who were off antipsychotics but taking other psychiatric medications, people still on antipsychotics but reduced the dosage, and people still on antipsychotics but were at the same or higher dose. And that broke down to about 54% of the sample was off antipsychotics, either taking or not taking other meds, and about 45% was still on antipsychotics. So one of the things that's often asked about antipsychotic discontinuation is whether the presence of psychotic symptoms indicates that withdrawal should not be attempted. And we found that only accounted for about 10% of the difference between the different cohorts. Of all the people who were off all medications, 40% of them still reported psychotic symptoms, and 52% of the people who were still on at the same dose or higher reported psychotic symptoms, indicating that the presence of psychotic symptoms was not the central reason for being able to come off or not being able to come off. So there was a very strong correlation with the length of time that people were on antipsychotics with the likelihood that they would still be on antipsychotics. And the less time you're on, the more likely you would be able to come off. But this was not exclusive. It's really important that this was not an overwhelming predictor. In fact, we did have more than 1,000 respondents who were on antipsychotics for 10 years or more, and 41% of those were able to come off. And we had 368 respondents who were on for more than 25 years. And of those, 21% were able to come off antipsychotics. So a very strong connection between the likelihood you can come off, but it wasn't an exclusive predictor. And that same trend also held with how difficult it was to come off. Of the people who were able to come off of antipsychotics, it was rated much more difficult the longer that they had been on. And the difficulty reported coming off didn't change that much between people who were off all medications and people who were off just antipsychotics, suggesting that maybe there isn't that much of a difference in the likelihood of discontinuing if someone is also taking other meds. Most of the people in our sample came off abruptly cold turkey, and it does seem to make a difference with those who stayed on and were able to reduce their dosage. But otherwise, gradual reduction didn't seem to correlate that clearly with being less likely to be on. So we asked people if they had lasting negative effects from the antipsychotics that they took, and it was about the same yes, no, up to about a year of exposure. But then after a year of exposure, you start to get a very strong trend that people are much more likely to report lasting negative effects if they took the antipsychotics longer. So in terms of lasting negative effects relative to exposure, it really looks from our sample that the exposure is the primary driver of lasting negative effects, because we're not seeing people who are going off abruptly or cold turkey reporting more lasting negative effects relative to those with a gradual reduction. And of course, there's a big question a lot of people asking, am I at greater risk from staying on the medications longer, or am I at greater risk from doing too fast of a taper? And the data from this survey is showing that it's the exposure that presents greater risks, not the faster taper. Switching to another mic here. My colleague Lucy from IIPDW asked an important question. Does the report of lasting negative effect change based on the length of time that people have been off antipsychotics? And unfortunately, the data are quite grim here, as people are reporting that the lasting negative effects remain consistent. And what's important about this figure as well is that this includes everyone, regardless of pace of coming off. So again, we're seeing that the length of exposure is the strong influencer here. We also asked the question a slightly different way. I won't get into the data, but when we ask about specifically withdrawal effects distinct from lasting negative effects, so the assumption is that the onset was only as a result of initiating discontinuation, we do get similar results. except for length of time off the drugs, where longer length of time does show diminishing long-term withdrawal effects. There also is evidence in the data showing that greater independence from prescribers actually leads to more likelihood to withdraw, which could be explained by prescribers predominantly being inexperienced with deprescribing and the withdrawal process, and actually biasing patients towards staying on the antipsychotics when difficulties arise. So we asked people who were able to come off, who were not able to come off, who were able to reduce their dosage, who were not able to reduce their dosage, whether they were taking other meds or not. We asked them, how did the process of trying to come off of antipsychotics affect your emotional health? And it was overwhelmingly 82% said that either their emotional health was improved or was about the same. Only 18% said their emotional health was worse or much worse from having attempted antipsychotic withdrawal, whether they succeeded or not. And that was even stronger with the question around physical health. We have 86% saying their physical health was better, much better, or about the same, and 14% saying it was worse or much worse. And this is significant, especially in the context of so many people saying that they came off abruptly cold turkey. So I think this is one of the most significant findings of this survey. We asked people whether they were glad that they tried to discontinue. And we asked everybody whether they were successful, whether they were not successful, no matter how hard the process was, whether they felt they were worse off or better off for having tried. And still, overwhelmingly, 92% said that they were glad they tried to discontinue. Even the people who continued to be on antipsychotics at the same or a higher dose, 74% of those said that they were glad that they tried to come off. So some of the clinical implications that I'm seeing just from this overview is that there seems to be overwhelming evidence that patients find that the process is worth it. And this is very strongly counter to the caution that we often hear from prescribers, family members, and the general public, indicating that that may not be data-driven, that may be just related to people's fears. We did not find any clinical profile or demographic profile that precluded the possibility of successfully coming off. So there's no clear predictors that emerge from the data supporting the principle that everyone should have the right to attempt, if that's their choice, of course, consistent with people's right to informed consent and the right to refuse medical treatments as a basic human right. It does appear that prescriber involvement and relying on prescribers as support may actually lower the chance of successful discontinuation because of prescribers' inexperience with the process. And overall, we consistently see in drug withdrawal research that individualized approaches are really called for, that there's no way to predict a specific pathway for any individual. And this has been mentioned by a number of researchers, Horowitz and Moncrief, write in 2024 that the rate of reduction requires striking a balance between exposure and too rapid reduction. Then that's going to vary by each individual. Wunderlink in 2024 also said that there's no way to predict, and so everything needs to be individual. And the respect for an individual's choice is one of the things that psychiatry has historically done. People have been invalidated in their human right to make their own choices in terms of their care, and it's clear that the data are consistent with everyone having that right. Because on an individual to individual basis, there's no way for a clinician to predict what's going to happen, and therefore they have no evidence-based stance to judge that a patient's decision is going to fail. So please feel free to get in touch with me. This presentation is available online, and you can also view the survey questions and sign up for updates at antipsychoticwithdrawalsurvey.com. Thanks a lot.